We are live, please.
Good evening, everyone. Welcome to the iFocus online lecture 541. The topic for today is Clinical Optics 4, Catoptric Images, Emmetropia, Accommodation, Purkinje Shift, and Pinhole. For the session today, I would like to introduce the moderator for the session, Dr. Kanika Bhardwaj. She has done her MBBS from Mohan Kumaramalangan Medical College, Salem, Tamil Nadu, followed by a DNB of Ophthalmology from Eye Care Hospital, Noida, followed by a fellowship in cataract and refractive surgery from Center for Sight Eye Institute, New Delhi. Currently, she's an associate consultant in Center for Sight, Cataract and Refractive Surgery. She's also actively involved in training DNB and PG students and mentoring fellows. She's a recipient of multiple awards for Best Video, Best Paper, Best Posters at various conferences like AIOS, DOS, WS, SAO, etc. Ma'am has also received Young Researchers Award for her thesis. She's also published multiple publications on cornea cataract refractive procedures in various national and international journals. Welcome, ma'am. For the next part, I would like to introduce the esteemed chairperson for the session, Professor Monica Chaudhary. Ma'am is a retired senior optometrist from AIMS Delhi with over 39 years of experience. She is also the director of MCVI, which is Monica Chaudhary Vision and Eye Care Clinic in Gurugram, and the founder of Learn Beyond Vision, which is an online teaching platform. Her expertise lies in contact lenses and specialty lenses, myopia control, and orthokeratology, which she has pioneered in India since 2017. She also is very experienced in low vision rehabilitation and vision therapy, followed by pediatric eye examinations and amblyopia treatment. Ma'am has multiple awards to her name, like the Shrestri Award given by Delhi Citizen Forum in 1999, the Australian Leadership Award in 2012, and the Global Best IACLE Contact Lens Educator Award from Asia Pacific in 2015. She's published almost 5 books are authored, including Contact Lens Primer, Low Vision Refraction, and Lens Prescription. Welcome, ma'am. I would finally like to introduce the speaker for this session, Dr. Divya Agrawal. Ma'am has done her MBBS from AFMC Pune with 5 distinctions, followed by MS from GNEC New Delhi. Also, she's done senior residency from GNEC New Delhi, followed by ex-consultant at ASG Eye Hospital, Bhubaneswar. Presently, she's consultant at Center for Sight Noida. She's won Best Scientific Paper Presentation at APAO Bangkok in 2019, International Heroes Award in AIOC 2020. She's published many papers in national and international index journals and conducted various surgical skill training courses. She's also the executive member of International Society of Manual Small Incision Cataract Surgeons, the Delhi chapter. Welcome, ma'am.
Thank you.
I would now like to invite the speaker to begin the class.
I hope my screen is visible at present.
Ma'am, the slides are not yet. Yeah, now they're visible, ma'am.
Okay, so a very good evening to everyone. I will be speaking on catoptric images, emmetropia, accommodation, Purkinje shift, and pinhole. So let us cover each topic one by one. So coming to catoptric images, these are also known as Purkinje-Sampson images after the people who discovered them. These refer to the images which are formed inside the eye as a result of the reflection occurring from each refractive surface of the eye. So let me just turn on my pointer. Yes. So here you can see that the incident light beam coming from a source is first reflected from the anterior surface of the cornea. This is the first Purkinje image. The second is from the posterior surface of the cornea. The third comes from the anterior surface of the lens, and the fourth from the posterior surface of the lens. So these are the 4 images. Now let us see what is unique about each of these 4 images. So as you can see now, this is a picture from a pseudophakic eye under the operating microscope. So these 3 lights, this is what is forming the first Purkinje image. So here I have made a small table. You can see the first, second, and third are all virtual and erect, and the fourth is a real inverted image. So here we can see this is a very bright and sharp image. Where is this used? This is used in the Hirschberg test and when we do keratometry. The second, which comes from the posterior surface of the cornea, this is a very diffuse image, and in clinical settings, mostly we cannot see this. This is also virtual and erect. The third one, which comes from the anterior surface of the lens. Now, this is what we see the shimmering reflex specifically in pseudophakics. This is the one which is absent in aphakic. The fourth, which is the real and inverted image, here you can see that this is inverted. So this is also absent in aphakia and in hard cataracts because the light rays cannot penetrate and reflect from the posterior surface. This is the only one which is a real and inverted image. So the uses, as I mentioned, is when we do keratometry. This is when we see the image reflected from the anterior surface of the lens, cornea. In the Hirschberg, this helps us in squint assessment. You see the reflection in vis-a-vis the position of the pupil. So if the light rays are in or out with reflection to the pupil centration, this helps us in determining esotropia, exotropia, hyper or hypertropia. While implanting a lens, if you're not sure whether it has gone completely into the bag or it is a sulcus and bag placement, you can assess the IOL tilting by this because these images will then not be in line. Also, phacodonesis you can assess by asking the patient to move their eye on the slit lamp and assessing these catoptric images. The next topic is Purkinje shift. Again, this was described by Johannes Purkinje. This is the tendency of peak luminance sensitivity of the eye to shift towards the blue end of the color spectrum, especially at low illumination levels, which is part of the dark adaptation system. So Purkinje noticed that the same red flowers that he sees during the day, when he would go for his early morning walk during dawn, he was not able to distinguish the red color of the flowers from the green leaves. So then he postulated that there must be two separate pathways which are working during day and night, one for color and one for contrast. Now we know that rod and cones are sensitive to different spectrum of the visible light. So cones are more sensitive to about 500 nanometers and rods to just under 500 nanometers. So cones will contribute more to red color vision. Whereas during dusk, when our rods are active and only 500 nanometers we can see, the light spectrum shifts towards blue. And this has also been found in some deep sea fish. Although the evolutionary advantage is very difficult to explain, but it has been found not just in humans, but also in deep sea fish. So what is the practical implication of the Purkinje image, Purkinje shift? So here you can see, most of you would have noticed that car tail lights are red. But have you ever wondered why red? Why could they not be blue? That is because when you are driving at night and your eyes are in the dark adapted state, the red tail lights are very less distracting. Whereas if you see even one broken tail light and has a bright white light, that will give you a lot of glare. So that is the practical implication. Another implication is in submarines, which remain under deep sea water for a long time, and you remain in a dark adapted state. In that case, these control rooms are red in color to interfere least with your dark adapted states. Similarly, in airplane control systems, all the dials have red buttons on them to maintain your dark adapted state and to decrease any distractions while you are flying or controlling the submarine. The third is a pinhole. Pinhole is a very important instrument, a very simple instrument in our refraction sets. So let us see some points about our pinhole. So the purpose of a pinhole is to contract the image cone and allow only the central unrefracted ray of incident light on the retina. This leads to a sharp image being formed and also increases the depth of focus. So when a patient walks in, you check the vision and you put a pinhole. you can differentiate refractive errors from any other cause of decrease in vision, because this temporarily bypasses the refractive errors by creating a sharp but dim image on the retina. So here you can see that the image was being formed ahead of the retina. But when we put a pinhole, there is no need for any refraction. The central ray passes through unrefracted, and a sharp image is formed, although it is dim because some of the light rays have been stopped. So this is the construction of a pinhole you would have seen. The central hole in the middle is about 1 to 1.2 millimeters, because less than 0.5 millimeter will decrease the vision actually because of diffraction. It comes in two designs, one which goes into your trial set. The other, when you are checking vision, there is a small window here with this flap with multiple perforations. This goes over the nose bridge, and when you ask the patient to read, you first open this flap and the patient checks his vision. And then on closing the flap, you get the pinhole best corrected visual acuity. So the uses of a pinhole: the first is to determine the end point of refraction. How do we know how much to refract this patient, or if the patient is amblyopic? If a patient of 6 by 60 comes to you, you give him the refraction that comes on your retinoscopy, still the vision is not improving, say beyond 6 by 12. If you put a pinhole, you know that the vision is not improving beyond 6 by 12, and maybe this patient is a amblyopic patient. So how much to refract, how much to keep going on, you can tell the patient that this is the best possible correction that is possible for you. Also, we can use this to triage in mass camps. If you have 1,000 patients, all of them cannot be seen by one doctor. So you can ask the optometrist to simply take a pinhole, check vision for each patient, and pinhole visual acuity for all of them. So simply those patients who improve to say 6 by 9 or 6 by 6 can be triaged to be refracted at a later state. Those patients who are not improving with pinhole, they may have some retinal pathology or a lenticular pathology like cataract, and they need to be dilated and checked. So a pinhole is a simple device which helps you differentiate between these patients. There are some kind of plastic glasses which have multiple perforations and aid as a low vision aid for low level of refractive errors, although now they are not recommended. But historically, these glasses were there in those places where doctors could not reach and give and dispense correct power. Certain patients, like those coming with a traumatic iris injury and they don't have iris tissue and are permanently in a state of dilation, if you need to plan a pupilloplasty for them and to check what is the best visual acuity you can achieve, to explain to the patient, or if the patient has been dilated at some other place and has come to you, you can put the pinhole and determine his best corrected refraction. The same principle has been used in implants like the camera inlay, or here you can see this pinhole IOL. How this works is by increasing the depth of focus to give some amount of near vision to the patient. So these are the uses of pinhole. Now, emmetropia. So why is emmetropia important to us? Now, when we have advanced so much in modern surgical technique, patients want supervision, eagle eye vision, or perfect vision. So basically, they want emmetropia from us. So what is emmetropia? It is the normal refractive condition of the eye in which, when accommodation is relaxed, the parallel beam of light are all brought accurately to a focus upon the retina. This is an emmetropic state. So now this is the end point of our refraction. Especially in myopes, you have to be very careful not to over refract them. So from myopic, you take them to just emmetropia and not overcorrect them. In patients undergoing LASIK surgery or premium IOLs, we have to consider all the higher order aberrations, the corneal tear film, everything, because there are some commensal aberrations. And if you correct these, then you will end up making the patient a little unhappy. So emmetropia in this patient would not be correcting all the higher order aberrations, but preserving some that is important. Also, if an infant comes to you with cataract, you have to tell the parent that this cataract is going to impede the emmetropization process and explain to them how early cataract treatment is essential for the emmetropization to occur in this child, or as an adult, they would have a very high myopia. So emmetropization is the natural development process where all the refractive components of the eye, whereby the lens, the cornea, and the axial length, they adjust and coordinate as a child grows to achieve emmetropia. Now, when children are born, they are mostly hyperopic. And as they grow, this hyperopia, which falls in a Gaussian curve, shift more towards a leptokurtosis. That means more of them than expected by chance are towards emmetropia. Very few remain in hypermetropia, or very few go into very high myopia. Mostly it is centered abnormally. You can see this would be the Gaussian curve, but they are abnormally emmetropic. So this is a homeostatic or a feedback process which guides our eyes towards emmetropia. They have both active and passive components. The passive component is the enlargement of the eye. The eye, which is 18 millimeter at birth, hyperopic, gradually grows. So naturally from hypermetropia, it shifts towards emmetropia by decreasing the diopteric power of the eye. The cornea, which is very steep initially, is gradually flattened. The lens is power is also reduced by lengthening the radii of curvature, and the effectivity of the lens is also reduced by the deepening of an anterior chamber, which is very shallow at birth. The active mechanism, that is the feedback from the image which forms on the retina and leads to adjustments of the axial length. When there is a problem in any of these processes, instead of emmetropia, we end up with ametropia. So here to summarize, at birth, there is an axial length which is 18 millimeter or hyperopic with a steep cornea and a shallow AC. Slowly it increases up to 23 millimeter of axial length. The cornea flattens. This happens very rapidly between 2 to 8 weeks of birth, and the anterior chamber deepens. Then by the time the child reaches puberty, the axial length has increased a little bit more by 1 to 2 millimeter, and the rest of the emmetropization changes are by changes in the lens. The retina or the retinal pigment epithelium, when the image falls on that, that presumably releases some biochemical messengers like dopamine, which changes the choroidal thickness. And these biochemical messengers modulate the growth of the underlying sclera. So this is responsible for the development of high myopia, which would be covered in other classes. Form deprivation, supposing the lids are sutured as in primate monkeys during testing, or if there is a dense corneal opacity, so this leads to myopic shift. So just to graphically demonstrate, we are born hyperopic at birth, and gradually all of us reach emmetropization. If there is a failure of emmetropization, either we progress into myopia or we may remain hyperopic. So next, to come to accommodation. The accommodation is the mechanism by which the eye changes its refractive power by altering the shape of the lens in order to focus objects at variable distances. Now the lens becomes more spherical with decreased equatorial diameter and ciliary body diameter, and axial length thickens. So here we can see an MRI. So this is without accommodation, and this, the patient was given a +5 target. So you can actually see on the MRI the increase in the axial thickness. So what does this accommodation do? Basically, the far point is the point where the image falls on the retina with no accommodation. That is the position of the object in centimeters. The near point is the nearest point that you can see with the maximum accommodation in play. Now, the range of the accommodation is the distance between your far point and your near point. Again, this is in centimeters. The inverse of this is the diopteric power, like 100 upon the distance, that will give you the power in diopters. Like 100 upon 20 would make it 5 diopters of amplitude of accommodation. So the amplitude would be P minus R. That is difference in the power between rest and a fully accommodative eye. So here you can see in a fully accommodated eye, the far point is somewhere here. It is not in a natural state of the eye. There is a general tone of the ciliary muscle. So it is not at infinity. It is somewhere between infinity and near is your far point. Your near point is when you are accommodating fully. That is your near point. So this would be the range of accommodation, and the 100 upon the range would give you the amplitude. Again, when you're trying to read near, there is also some amount of convergence that occurs. So for each prism diopter convergence which is occurring for each diopter of accommodation, that is your AC by A ratio, or the accommodative convergence by accommodation ratio. So that should be between 3:1 to 5:1. So we will cover what are the errors in accommodation later. So only in 1800 we found that accommodation was actually due to change in curvature of the lens. Now let us cover some theories about accommodation. So the earliest was given by von Helmholtz in 1856, in which he mentioned that the lens, which is an elastic structure, is stretched and flattened in a normal state by the suspensory ligament tension. The contraction of a ciliary muscle when we want to look at something near shortens this ciliary ring. This shortening leads to relaxation of the suspensory ligament. This is important because this will now contrast with the other theories that we will cover. So contraction of the ring leads to relaxation of the ligaments, and this leads to the lens becoming thicker. Here you can see that when this ciliary ring shortens, the zonules here, which are initially taut, are now relaxed and all curled. So this leads to shortening of the lens diameter and thickening in axial direction. So this is the theory of von Helmholtz. So Goldstrand has made a mechanical model based on Helmholtz theory, in which he said that the elasticity of the choroid is more than the lens in an accommodated state. So he has made a mathematical pulley-like diagram to explain this mathematically. So when the pull on the circular fibers of the ciliary muscle occurs, that is like a weight on this pulley. It shifts this system as such that now this point moves up, and this lens, which was stretched like this, now becomes short and thickened. So this is the Goldstrand model, which is explaining based on a pulley system, which helps to take the accommodated shape of the lens. Now, Schörning's theory was in opposition to von Helmholtz theory. He said that increased zonular tension, this causes compression rather than passive relaxation, which Helmholtz said. So the central part of the lens is bulged and the peripheral is flattened. Now, Sachar in 1992 has given a very similar theory that of Schörning. He has compared the lens to like a balloon. So like if we pinch these edges of the balloon, we will be shifting the fluid towards the center. So he said when the equatorial zonular tension occurs, he has said only the equatorial zonules are important, not the anterior posterior ones. So these cause the central volume to increase and the peripheral to thicken, and the pull is in the outward direction. So here you can see when the ciliary muscles are contracting, the central zonules are becoming tighter. There is this pinching effect that occurs in the periphery. The central part of the lens becomes thicker and more steeply curved. And in presbyopia, why is there loss of accommodation? Because slowly, as lens is an ectodermal structure, how we have hair which grows over time, slowly this lens is also grows over time at this perilenticular space. So initially now this zonule which was tight now becomes lax. So even when the ciliary muscle contracts, this zonule is not tight. There is a laxity here. So the pulling of the ciliary muscle is not able to pull this zonule tight. So here there is tightening of the zonule, which is causing accommodation. In Helmholtz theory, there was relaxation, which was causing a bulging of the lens. So that is the difference between the two theories. So Sachar even made a scleral implant, which is made placed in partial thickness tunnels all around. So in this, he postulated that when we put this implant, it pulls the sclera in an outward direction. Consequently, the ciliary body is stretched, and the laxicity which is caused in presbyopia because of loss of space between the zonules and the ciliary body, that is counteracted by putting this implant. And he claims that presbyopia can be reversed to some degree by placing these implants. So here we can differentiate between the two theories. In Helmholtz theory, contraction of the ciliary body leads to relaxation of these zonules and expansion of the lens here. Whereas in Sachar, contraction or outward pulling of the ciliary body and outward pulling of the zonules is causing stretched at the equator and stretching here of the lens. So this is the difference between the two opposing theories. Then in 1970, a catenary or hydraulic suspension theory was proposed by Coleman. In this, he postulated that the lens and zonule and the anterior vitreous, they comprise a hammock or a trampoline-like diaphragm between the anterior and the vitreous chamber of the eye. So contraction of the ciliary body actually causes a rise in the vitreous pressure, like a hydraulic effect on the lens, and this causes an anterior displacement. So what is actually a catenary? I will explain. This is a position or a curve that is formed between a chain that is suspended between 2 points, like here on a chain. Even in a spider web you will find. So in nature, whenever a zonule or whenever a capsule or a chain is left to be on its own between 2 points, it forms this shape. So Coleman has said that these two pylons of a bridge or this bar is like the ciliary body, and the lens capsule is basically hanging in a catenary fashion between them. And stretch on this ciliary body will cause a push from the vitreous. And in presbyopia, there is loss of this pressure gradient because of increase in the lens volume. So this theory was responsible for the development of the first accommodative IOL or the crystal lens. So here you can see like how a trampoline is like a circular ring which is suspended by and held taut between a rigid structure all around. So when this contracts, there is a push from here. And you can see this lens had two flexible segments here. So instead of being in a posterior plane, this is pulled slightly anteriorly because of the push from this lens vitreous diaphragm. So directly ciliary body is not contracting, just like the pylons of a suspension bridge, it remains stable and it changes the vitreous composition. So these were the theories of accommodation. Now, what are the types of accommodation? So we have tonic, proximal, reflex, and convergence. These are the types of accommodation. So like I explained during when I covered the range of accommodation, the tonic accommodation, your far point, is due to tone of the ciliary muscle, even at the absence of any stimulus. So it will not be at infinity, but some intermediate distance, which can vary for each person. A proximal accommodation, when you're aware of something that is near, wherever it may be, some amount of accommodation is induced by that. When you sit on an autorefractor, you are aware that you are going to look near. So some amount of accommodation is generated. Reflex accommodation, which is an automatic adjustment to blur. Convergence accommodation, that is the amount of accommodation which comes with convergence. So this, when we, as I explained to you, is the AC by A ratio, which is measured clinically. Now coming to the accommodation reflex. So basically when the eye forms any image, the optic nerve, the optic chiasma, optic tract, lateral geniculate body, I will explain this better here. You can see that the light rays, now they are going to the optic nerve, chiasma, optic tract, and this lateral geniculate body, where now the third order neurons will go into the occipital cortex. So this is your afferent pathway. Now here, the oculomotor nerve neurons are between these. This will then be transmitted to the frontal lobe. All right. And here the internal capsule and crus cerebri then transmit this to the supraocular nuclei, oculomotor nuclei, and the oculomotor complex. And the efferent pathway, now this goes through the Edinger-Westphal nucleus and through the oculomotor nerve to the ciliary ganglion. Here, the postganglionic fibers, they go through the short ciliary nerve and cause iris sphincter constriction, ciliary muscle contraction, and from there, the zonule and changes in the shape of the lens. Some of these go through the oculomotor neurons, through the oculomotor nerve, and to the medial rectus. So this leads to convergence. So the 3 C's of the accommodation, that is convergence and contraction of the muscles and pupillary constriction, that occurs. So this is your accommodative pathway. So there are a few anomalies of accommodation which can be classified as increased accommodation or decreased. So decreased accommodation is much more common, which can be insufficiency, ill-sustained accommodation, inertia of accommodation, or paralysis. So we'll briefly discuss each of these. The most common that we know is presbyopia. This is a physiological insufficiency in which near vision decreases. So you tend to put the reading object far away from you to reach your far point. So this is basically age-related change in the lens because of decreased elasticity of the lens capsule, increased in size and hardness, that is sclerosis of the lens substance, and some amount of decrease in ciliary muscle power. Also prematurely may occur in uncorrected hypermetropes, some cause of premature sclerosis of the lens, or also something that you should not miss is glaucoma. Many a times you will see patients who are 35, 36 coming with a complaint of near vision. So please do not give them near vision glasses. Please dilate everyone who comes with near vision complaint and check for glaucoma. The insufficiency of accommodation, this occurs where the accommodation is less than the normal range according to the patient's age. So again, this can be due to anemia, pregnancy, or any weakness in the body. This can cause that. Ill-sustained accommodation is accommodation fatigue, which is an initial stage of insufficiency, again because of convalescence from any debilitating illness. So all these patients would complain that they have, at the end of the day, they feel very tired. They have blurred vision when they try to work on a laptop or read a book for a long time, headache, eye strain, fatigue, or a dull sensation, pulling sensation along the eye. So you can curtail their near work and increase the illumination in these cases. Inertia of accommodation basically means that in them, they are not able to achieve the amplitude of accommodation as quickly or for prolonged periods of time as in normal population. Or they have difficulty in changing the focus. They get fatigued. So again, we have to give them accommodative convergence exercises or correct the refractive error. Paralysis of accommodation. So this is what is called cycloplegia or complete absence of accommodation. Most commonly, we see this when we dilate a patient with atropine humide or any other cycloplegic drugs, or any internal ophthalmoplegia because of diphtheria, diabetes, or any other problems. In third nerve palsy, you see this. So again, these patients would have a blurring of vision. They may complain of micropsia, in which objects appear smaller than they are because of a false sense of distance, because they are not able to accommodate. And they will obviously have a enlarged pupil. Now, cases which have excessive accommodation, in which the accommodative response is greater than the actual stimulus, in which there is a functional increase in tone of the ciliary muscle and a constant accommodative effort. So young hypermetro, they use excessive accommodation as a physiological adaptation. or a young myope having a lot of excessive near work and a lot of convergence may generate this accommodation. So again, they will have a lot of eye strain and photophobia, headache. So you can correct the refractive error and they will improve. Sometimes you see spasm of accommodation, which is again abnormally excessive accommodation. Sometimes it can be because of drug induced, as in after myoptics, or spontaneous, because when the patient is trying to correct a very high refractive error, they may have this. Or a bad reading posture illumination may sometimes cause this. So then you may have some asthenopic symptoms and vision disturbances. So just relax these patients with atropine and don't allow them to work very close for a long time, and they improve with time. So these were the errors of accommodation. Thank you so much.
Thank you, Divya ma'am. That was very nicely taken and explained very well. I'm sure the students will benefit. Garvita, do we have any questions on any of the online platforms for ma'am?
No, ma'am, no questions yet.
I would like to invite Monica ma'am to also speak on the topic based on her expertise in the subject, ma'am. Ma'am, we cannot hear you. I think your audio is muted.
Thank you so much. And I would appreciate such vast, huge topics so well covered. So, yes, understanding Purkinje images and all the basic words as we are in the eye care field makes sense. But very important topics too that the people should understand is emmetropization, especially with the progression and myopia which is coming in. And the second is the accommodation. In my clinical practice as an optometrist also, and of course you would also find the whole system of accommodation anomalies are building up. It's all thanks to those digital screen nears and online and all these gadgets. The whole process of accommodation in young adults is going haywire. So it's just not those four words of theory understanding the types of accommodation, but it makes so much sense in how to manage them. Vision therapies and other things are a big, I think, future in clinical practice as to move ahead. So every headache that we find is just not thinking only of refractive error. And so a key emphasis I would like to say is that everybody should take a serious note on accommodation and binocular vision anomalies and even the AC by A ratio. It means a lot now. We do find many children having squints, and it's only the AC by A ratio which is getting into an anomaly in that. The next is Pinhole, a tool which is excellent but always missed out. So whenever there is a 6x9 or even 6x partial, I think we should ensure that we put in a pinhole to see that even if it's an optometrist working under you. And it's my observation, even optometrists just say, think that he missed half a line in 6x6. But the pinhole tells us a lot more, many things. And if the pinhole is improving and the refraction is not improving, the important aspect of irregular astigmatism, which is there, has to be also ruled out. Macular pathologies, pinhole, I mean, these are the times which, as a primary eye care in optometry also, and especially if you are doing the refraction, pinhole tells us a lot more something's going wrong inside, something's going bad here, the amblyopias and others. So one more important clinical thing is that make pinhole an important tool in your pockets and make sure that you redo the things every time you feel this has not improved to the best sharp vision. And rest all was well covered. We don't have questions. And of course, thank you. And if any questions, we'll answer.
Ma'am, I would like to ask one question. Like, we have so many patients coming to our clinics, and it's that probably that they don't want to accept that now they're aging or the advancement of presbyopia. So they keep asking us, ma'am, is there anything we can do to delay this presbyopia? And if we can manage without glasses for some time, or if it is compulsory to wear glasses every time we are doing a near activity. So would you please throw light on these questions, ma'am, like how to console them or
As a
them?
presbyope myself, it is life is too much near. So presbyopia begins when at the birth only. It says your amplitude of accommodation is receding. Now we do find somebody who's 47 hasn't started reading using presbyopic corrections, and we do find somebody 39 also using presbyopic correction. Now it is short people have, or people those who have a habit of holding near. Now, if the amplitude of accommodation or near point of accommodation, as Dr. Divya said, recedes beyond your working distance. So whether we prescribe the glass or not, what is the habitual? So initial stages, patient just go a little far off, holding the things a little away, making the light more brighter, contrast is enhanced, and they can avoid using the correction for some time. But in all probabilities, the screens, which are the mobile phones, are held at a distance where we find now presbyopic correction need is important even in young people. If somebody is a hypermetrop, he'll need much more earlier because his near point of accommodation will recede faster. So it's all the science of understanding where is the near point of accommodation in presbyopia. Now, facility was mentioned by Dr. Divya, and for years before, unless now that we have those Presview drops, which have been also tried in some patients for early presbyopes, and clinically, yes, some patients have found it good. So, in case of near point of, in case of presbyopia, earlier what we used to do, we tried for ourselves to, we have these accommodation flippers. These are like gym for the strengthening up of the accommodation facility. So if we just use these flippers for about a minute a day or 2 minutes in a day, we enhance the facility by which it works. In many cases of presbyopia, it is inertia. Inertia is because you're too much engaged in near activities, and suddenly looking from far and far to near, it takes time for the patient to focus. Now, these are the patients who should not be actually given the presbyopic correction or that plus add, unnecessary plus add, but it's because of the inertia which is happening. So much of science in just the near vision, which is so much correlated to the types of accommodation which she mentioned. That's why I said our every patient has to be the near point of accommodation. What's his working habit? Now you ask anybody, what's your habitual reading? It's so common for optometrist, as you would also supervise them. What is the reading correction? They are used to the age-old editions. Now, patient who's early presbyope has started learning to hold the book far away. And you ask him, he chart pakdo, and he holds the chart. And the edition, no, I can read in 6 because he's gone far away, he's reading far away. Now, the distance is 40 centimeters, which is ideal to be reading that smaller part, and then the contrast of the charts and other things. So, for a patient, they just recede further and try managing reading. But it is the eye strain, asthenopia, and other things which do matter a lot. So near point of accommodation should be measured and then decided whether this patient needs presbyopic correction or can delay it further.
Correctly said, ma'am, and very nicely explained. Are there any exercises apart from the accommodation flipper, as you told, ma'am? Any common exercises that can be done to improve the facility or reduce the inertia of accommodation in day-to-day practice?
So excessive near work and going closer to continuous accommodation, so the patients get fatigue into it. It is a problem, so we just advise on those kind of exercises. But the general debility and health makes a big difference. So we also find patients who have some systemic problems and other things. They also dim light reading, contrast the pupil size. I forgot to mention that the pupil size plays a big role into it. And if the contrast equity of the patient may be 6 by 6, but suppose the contrast equity is poor, he will be able to read on that chart, but he will have the complaint of blur and not being able to see well for near. So enhancing contrast is just making lights brighter. Pupil size makes a big difference. Sometimes just because of that, people need extra addition or corrections to be done. Not much to say, but we do say dim lights, lying down, mobile screens, late ke nahi, raat ko nahi, excessive mobile, and we always go less than 40 centimeters in most of the cases when we are on the screens. And Harman distance is another word. So the distance which you have half of your arm when you fold it is the ideal Harman distance, which should be minimum where the near object should be kept. So I think it's more of habits and visual hygiene which make a big difference in seeing certain people not getting into presbyopia so soon and some taking it so fast.
Yes, ma'am. Ma'am, just a small word about these new medications that have come up for children now who have started to have difficulties in development, and they are developing a lot of myopia. And it's like Divya ma'am already told, it's actually improper emmetropization, or we can say it's a faulty emmetropization that's happening. And we have so many concentrations of so many, dilating drops in diluted concentrations. So how do they help with emmetropization process and to control the myopia process, ma'am?
So atropine 0.01% has been universally so far advised to slow down the progression. It is playing role in peripheral defocus and hence the eyeball elongation. Now, this percentage has been next studied and debated, and the percentage has gone to be higher to be more effective, which is 0.05%. Atropine is still controversial in many studies, but so far, yes, there has been a reasonable progression slowdown with it. Atropine combined with those myopia control glasses or orthokeratology. And my experience with orthokeratology, my first patient was orthokeratology for myopia control for years that I have done. Excellent results on orthokeratology. I have yet to see something. My clinical experience has started showing me a lot of exophoria and IDS. However, the initial studies proved that atropine is not causing any imbalance and does not impact the accommodation and things like that. But we've started finding binocular vision anomalies in long-term, 3 years, 4 years use of atropine. We started finding intermittent divergent squint exophorias. The sensitivity to the light also increases. So we never know whether these complications may be observed with time and then there is some action taken on it. So atropine drops as of today are very effective in children which are like, but combination with spectacle or orthokeratology has proven to be the best. And atropine should be started judiciously in these children because once you start, it is no stop, and 2 years is minimum what they say it should be used. But we've seen even 5-year studies have come that it should be continued for 5 years or so. Rebounds are highly known, and I've seen it myself also. So parents would just stop atropine if they were not seriously told, or they did not take it seriously. We've seen a case from -2 to -5 within 6 months dropping over of atropine also in this case. So still at least something is better than nothing. And if I have a 3-year-old, 4-year-old myope, we know certainly is going to grow, eyeball size is going to grow. And spectacles are pretty expensive. Orthopay is again worse. So at least something for the parents to start.
Divya ma'am, how to identify in the general clinics that if a child or a young adult is having a spasm of accommodation, like what's the clinical sign that points towards spasm of accommodation, and how to diagnose that and treat that accordingly?
So you will find a young patient, maybe very anxious, has some exam, has been studying all night, or has some project they have to submit, and they will come with a lot of asthenopic complaints, pain, may have some watering, and when you test, you will find a little bit of myopic shift on an autorefractor. When you dilate them and you call them maybe the next day, you will find that they have improved after dilation. And uh, otherwise, after when you follow them up, they have no significant refractive error. But at that point of time, when you had seen, they had a significant myopic shift you can document. So these would be the cases that you would know they have spasm of accommodation.
Yes.
So
Ma'am,
I'll
I
add,
also
I'll,
had first.
I'll add to this spasm the dynamic retinoscopy and the MEM. So our retinoscope, when we do, we immediately get to know if the MEM is not between that plus 0.25 to 0.75. If there's shifting, that means it's spasm of accommodation. We find a lot of this in adults also nowadays. And the very simple clue is the acceptance AR. Your AR's values will not be stable values. You suddenly find 3.5 and then 4.25, 2.75. So there's a fluctuation. And if the optometrist can pick up, then just taking a printout, it is a case where the accommodation is too much fluctuating. Retinoscopy values, MEM, can also pick up these. The next is dilate, to be sure, and the dilated, as you said, the visual acuity suddenly is different. Treatment of these cases, just prescribe what you get under cycloplegia. Do not wait for PMT, because PMT they'll again go up.
Ma'am, for cycloplegia in such cases, which is the preferred drug of choice? Like,
So tropicamide doesn't work. Homide, at least in adults, or this. And if we find in children, even homide is not too good enough, we may add CTC, cyclopentadate.
okay. Ma'am, I wanted to ask, like, it was my own clinical experience. One of my patients came to my clinic and she was going through some anxiety treatment, depression treatment, and she just very clearly mentioned that the moment she started her anxiety, depression medications, within a week, she started feeling that she's not able to see at near. So, is there any direct relation of these neurological drugs, and do they impact the accommodation so quickly, and can they actually cause difficulties?
Yes, so in our history taking, we do may ask patients about these antidepressants and others. So the accommodation suddenly goes haywire. And I don't know if it's a sleep pattern. I seriously did not read through, but I know there are a lot of research documents correlated to it.
I recently had a patient, ma'am, and she gave me a very specific history, although she is 45. But she said, ma'am, I was able to see everything a week before. And the moment my medication started, and now I cannot read. I was able to read things before at near. Now I'm not able to read. So probably I thought for the first impression that maybe she has never worn presbyopic glasses before. But once we did examine and we found out that, yes, what she's saying is related, there is literature on the topic as well. So I think one of the more important things is also the medication history that the patient is on, and we have to relate it clinically.
Today
So
only there was one lady who was like plus 0.5 only presbyopic. And again in the history taking, she says I was 1.5 months back on antidepressants. So
definitely we need to read the effects of these. Like this one who presented to my clinic was on fluoxetine and duloxetine both. So probably that must have impacted her accommodation. Thank you so much, ma'am, with your experience and your insights and for enlightening us. And thank you so much, Divya, ma'am, for such a beautiful class and so well explained in detail and with very simplified terms and along with the clinical applications of each thing. So that was, I think, very good, and it should definitely help the students understand this tough topic. Sometimes they do get confused between far point, near point, accommodation. So it should be very helpful. Garvita, do we have any questions right now?
I have received one question from YouTube, ma'am. Dr. Wada Alfare, they ask, they need some clarification when ma'am mentioned any patient with myope. Please check for glaucoma. He needs clarification for that.
So I said if there is a patient who comes to your clinic and complains of difficulty in near vision, So always do check for glaucoma as well, because they many a times you would see that they have just gone and picked up some near reading glass of plus 0.75 or even plus 1 when they are 38, 37 even. But they actually had chronic glaucoma and that was being missed. So that can also lead to decreased accommodation. So glaucoma and accommodation are also related because all this is happening around the ciliary body, right? So that decrease in the outflow and causing of glaucoma can also present as loss of accommodation. So just don't see the anterior segment. Also always see the optic nerve in an early presbyo. Don't just say, okay, he has some near work and has difficulty and is N12 and you just give glass. Always look at the optic nerve as well.
Also, ma'am, practically we have seen that myopes have a good near vision, and also myopes have an association with glaucoma as well. So both of the things are somewhat, inclusive as well as contradictory. But like you rightly
Because
said,
myopic when they take off their glass, that is similar to adding their plus correction. So when they take off their glass, my father all his life he has never used near glass. He was high myope.
and even now we see patients who are in their 70s and 80s and who've not even gotten their cataract surgery done. They have dense nuclear sclerosis. They manage very well for near as
Multiple
well.
sclerosis is giving them second sight that
Yeah.
comes with the cataract.
Which is very funny. Today only one patient was like कि मैम मेरी मम्मी ने तो आज तक चश्मा नहीं पहना and I'm just turning 40 now and I've started requiring glasses for presbyopia. It really surprises me. How is that possible?
I just tell them that the day we can overcome accommodation, that person will get Nobel Prize. So please
Okay.
let me know who can find treatment for loss of accommodation because that is not possible.
Myopes who are frequently changing glasses, of course, we rule out the cornea keratoconus, but we have been referring for further investigation for glaucoma.
And it's
It's
very
it's a
difficult to explain to them. They're like, हमारा तो number कम हो गया है. Like the myopes, they typically are like कि हमारा तो number कम हो गया, हम पहले से ठीक हो गए हैं. It's very difficult to explain to them that okay, now your presbyopia and your myopia are calculating and adding and subtracting up together. But overall, ma'am, very nice class, and I think we are done with the time as well. I think we can call it a day and move on. Any other questions, Garvita? Oh,
Thank
thank you
you.
so much,
Thank you,
Monica ma'am.
everybody. Good
Thank you so
night.
much, Divya ma'am. Thank you, Garvita, for hosting
Thank you.
today. Good night, everyone.